Thanks very much. This is the group at Stanford that helped with this, and obviously there's a larger group of people that have contributed to the 189 patients that I'm using for the analysis here. The basis of my disclosure is research funding from Inside Tech. The basis for this is, of course, that our treatment planning depends on registering a CT to the treatment day MRI, and then adjusting the phase of the transducer, each element of the transducer, so that it penetrates through the skull and focuses in the thalamus. Skulls are very heterogeneous. These are CT scans from the various patients that we've been screening for our treatment. As you can see, some of the skulls are thinner, some of them are thicker, some of them are more trabeculated, some more cortical. Hounsfield units vary considerably across the range of our patients. We use the skull density ratio as a preoperative measure from the CT scan to try to predict the reasonableness of using FUS to treat these patients for their tremor. As you can see here, we have a range of SDRs, 0.61 on one end, meaning a patient that's predicted to be easier to treat, only took 9 sonications, only took 8 kilojoules, got a great result. Another couple of patients, 0.4 and 0.43, both requiring more than 30 kilojoules, one only 13 sonications, one 22. But here we have a patient in the middle, another 0.43 that only took 13 sonications and 11 kilojoules. So while SDR is a predictor, it's not a perfect predictor, and there's room for improvement. So we're going to talk a little bit about this. The basis for this is that in the US, for the clinical trial, actually the multi-center and multinational clinical trial that led to FDA approval, the SDR limit based on what was known at the time was set up as 0.45 plus or minus 0.05. So the lower limit was 0.4 for the patients that were treated as part of the clinical trial. For insurance coverage in Medicare, that has entered into the policy statements from some of the insurers saying that you can only treat patients that are at 0.45 or above. And so part of this analysis was in my effort to try and respond to that policy, because we felt that there are actually patients that with lower SDRs that can be treated, and we wanted to be able to demonstrate that. So first we looked at the distribution of SDRs on the left there across the patients that were treated as part of these 189 patients. And one thing I should mention, obviously, the 189 is a larger group than the original 76 that were in the ET002 trial that led the FDA approval. Since that original trial, people have learned improved methods for targeting, improved methods for energy delivery, how we ramp the energies, et cetera. Also, the population of patients in Asia, so in Korea and Japan, as those teams have developed more experience, they tend to have lower SDRs, and so by necessity, those groups have developed techniques that allow them to treat those patients. So, and those data are contained within this group. So one thing that we can see is the SDR on this distribution here, the average is about 0.52, and you can see the cumulative group of SDRs on the right there, with about 28% of the patients having an SDR less than 0.45 and 11% with an SDR less than 0.4. So a significant fraction of patients would be excluded by the current policy if it carries through. We looked at the clinical results, and one thing we can see is, kind of as predicted, that the probability of the target reaching 54 degrees Celsius, so choosing that as a reasonable target level for the temperature within the focal point within the thalamus, it's easier to reach that temperature target within the group that's greater than 0.45 SDR. About 91% of those get there versus 55% in the group less than 0.4. There's obviously a significant difference there. What's interesting, though, is that there is no significant difference when you look at the CRST scores at 1 year within these different SDR categories. So there isn't a perfect correlation. Yes, SDR can predict the ease of reaching 54, but it doesn't predict the clinical outcome in this patient population, which I found kind of surprising going into this. I wouldn't have predicted the results that I saw in this analysis. If you look at the cumulative percent improvement in CRST score at 1 year compared to the percentage of patients and group these based on SDR, if you look at the green line, that's kind of the standard patient above 0.45. If you look at the 50% cumulative improvement, we see that about 68% of the patients in that group reach about a 50% improvement at 1 year. But if you look at the group in the red, which is the group between 0.4 and 0.45, well, actually 79% of those reach at least 50% improvement. And if you look at the blue group, the group less than 0.4, even though they supposedly have a harder time reaching 54 degrees Celsius, still half of them get at least a 50% improvement at 1 year. So it's arguing that we shouldn't be excluding these patients and from our treatment. Now, the other thing to look at, of course, is, okay, we're effective, but are we safe? And so we looked at the rate of adverse events grouped by SDR here. And what we can see is the probability of an adverse event in the group less than 0.4 and the group between 0.4 and 0.45 is actually lower than the group greater than 0.45, which again is kind of counterintuitive. This may reflect the fact that the lesions that we're creating in these lower SDRs may be smaller, or again, it may be that we've been doing the higher SDRs in an earlier phase of our learning, and now the lower SDRs, we're doing it with that greater experience in mind. So in summary, the higher SDR does predict the likelihood of reaching 54 degrees, but it doesn't correlate with the improvement of the CRST at 1 year. Overall, if you look at the group less than 0.45 and the group greater than 0.45, 68% in both cases, 68% of the patients had at least a 50% improvement in CRST at 1 year, and it did not predict a higher incidence of adverse events either. So it seems that it's both safe and relatively efficacious to treat patients with lower SDRs. Thank you.
Thanks for this, Pejman. Really good work. The adverse event kind of mirrors the clinical experience. A lot of us, when we have higher SDR, we become a little bit concerned because the lesion shape and size is actually out of our control as compared to a patient who has a SDR around 0.45. So this important point, and I'm glad this data pans out that way.
That's an excellent point, and actually we've taken to the patients with the higher SDRs now, we intentionally apply masks from the get-go now to try and minimize the laterality of the spread of the spots. We're trying to control the size of the spot from the beginning now because of exactly the reason that you're saying.
I just have a quick question in terms of the sort of details of the data. So have you done an actual individual patient correlational analysis between the SDR and the outcome? I mean, you've shown the group data and said there's no correlation, but you haven't actually shown a correlational analysis between the individual patient SDRs and their outcomes. Have you guys done that?
Yeah, I can show you those graphs if you'd like.
Yeah.
I've got them on my computer. It's, the spread across the greater than 0.45 group is so broad that the between 0.4 and 0.45 and the less than 0.4 group are kind of subsumed within the range that you see across the greater than 0.45.
And the other thing is in terms of the low SDRs with the lack of adverse events, in terms of the patients that didn't have adverse events, what was their overall outcome as a group? With the low SDRs who had no adverse events, did they do well? Because just because if they didn't have adverse events, it means it's safe, but is it the same patients who are both safe and doing well in that low SDR group?
I didn't check to see that the ones that were in the 10 out of 20 were also the ones, but very few of those actually had an AE, as you saw, but we can double check that. It's a good point.
What about patient tolerance in that low SDR group?
Patient tolerance?
Yeah, the procedure.
In terms of how many of them were able to carry through the procedure?
Yeah.
I don't know the numbers of failures within that group. Yeah, okay. In terms of patients aborting the procedure, I don't know that number.
In terms of pain or a sense of heat?
Yeah.
Thank you.
Very nice work. One quick question. Does the adverse events include visible lesions within the skull?
No. These are the adverse events that are recorded for the various clinical trials. So
Okay.
they're thalamotomy related or procedure related events, non-transient ones. So the ones that occurred within the first couple of days and went away were excluded. This derives a bit from Dr. Fishman's paper as well, looking at how these adverse events are characterized and sorted, but it did not look at imaging changes in the skull.
Okay, thank you.
Last quick question.
It's wonderful work. Thank you so much. We reviewed our 98 patients done at Toronto, and we found SDR, as you found, has no correlation with the clinical outcome. But we had a series of 98 patients. We had around 17 patients who had SDR of 0.4 or less, and we could successfully do the thalamotomy lesions. But the requirement of energy was more for those patients. The energy requirement was more to delivery. And there was no correlation with the side effects.
Great.
Thank you.
Thank you.
70 is under review now currently.
Thank you.
Thank you.